have another minute to go.
Yes.
So you will move my slides, am I right?
Dr. Natarajan, you are slightly off center. Can you come in the center, please?
Now?
No, it's going the other way. Other side. Come in the center.
Okay. Now?
Yeah, better.
You please double click your image. You'll be able to see on this.
Is it okay?
Yes, sir. All right. All right.
Okay. So it's, I think, 6 o'clock.
Yeah, sir. You can start with.
Yeah. So welcome to this today's optometry webinar along with our retina specialist, the diabetic eye exam, why it matters and how optometrists and retina specialists team up to diagnose and treat retinal disease. So thanks to Sunita for asking me to do that, and Oli and everybody in the group, Ajit. The reason is I'm happy that I'm involved with optometry right from my childhood. How I see is I was assisting my father in the clinic when he was doing refraction and prescribing glasses. So I decided not to wear glasses. So I don't wear glasses even today for reading. I don't know how I can manage. And after that, as I think my grandfather and father were experts in the Duke Elder's refraction book. And so I didn't learn refraction well, even though I did, but I switched off to retina training. And then I was happy Dr. Bhardwaj started the Elite School of Optometry under Shankar Netralaya in Guindy with support. And then that showed ophthalmology and optometry have to work together. And he was a specialized retina from Boston, from Skippen's Retina Institute. So that's the reason he was always working with optometrists even those days. And my father also worked with optometrists. And my brother is an optometrist, which I forgot to tell you last week. And I think he was trained in India and then later in London School of Optometry. So my association with optometry goes along. And as a retina specialist, after doing surgery, I 100% depend on optometrists for giving the best correction. Maybe we do a retinal detachment with a PL, vision improves 3/60. We 100% depend on the optometrists who specialize in low vision aid, so that we can give a low vision aid for distance as well as near. And you can even make the 3/60 patient with the N36 to read N6. And I think today's specific, thanks to Ajit for arranging this diabetic eye exam. And I think that's my dream project as the president of All India, called screening through teleophthalmology to prevent diabetic blindness. We have 77 million diabetics with 58% not diagnosed. We are only about 25,000 ophthalmologists and maybe 10,000 optometrists and maybe many opticians. But I think in Aditya Jyot and in Shroff Charity in Delhi, we are using illiterate people who speak the local language. In Maharashtra, we speak Marathi and they don't know English, but they can do using the iPhone. I don't have any financial interest. They use the Remedio camera and they also use the Forest camera. And where they're trained well, they take better photographs than me and they can send it. And we use the offline AI or the AI for diagnosing diabetic retinopathy. So I think we have to team up with optometrists so that we can train further people. I don't know how many numbers we need to screen the 77 million. I estimate in 5 years, we should have a scheme. Every year, the person has to come for retina. And only patients with diabetic macular edema, background diabetic retinopathy, and pre-proliferative retinopathy should come so that we can treat them either with injection, laser, or surgery and make the patient see 6/6 along with the optometrist. And I think with this, I think I talked a little more. So sorry, Sunita. So I think you can take over. And it's my passion and I'm happy. That's the reason I voluntarily joined. And I would like to learn from David and also keep working with David and Mahesh for further publication to propagate this combination of optometrist and retina specialist. Up to you.
Thank you so much, Dr. Natarajan, for your word of wisdom. And that is the theme today, that we bring in how optometry and ophthalmology can work together to actually serve the nation. And we all know how much of diabetic capital India is and what worse can happen to it. So today we have with us Dr. Seemalal Gupta, who is the Associate Professor in Unsel University. None other than better for us because she's done her OD from Illinois and her MPH from the Alabama University, Birmingham. I would request to join in and introduce our speakers who are here. We'd love to share their experiences and move forward. With us today is also Dr. Sumit Grover. I think he doesn't need introduction. He's been one of the most popular ones, and he's also done his ophthalmology and his public health. He seriously looks into the model which can work together, where we can bring in and serve the population. With me, of course, is Ajit Bhardwaj and Rajesh Wadhwa, who are the key players in this kind of organizing these kind of webinars. And thanks to Olilullah, who's, of course, without him, nothing could have been better. So over to you, Dr. Seema, to introduce Dr. Mahesh and Dr. David.
Great, thank you so much, Professor Monica. This is such a special event tonight because having optometry and ophthalmology come together to present to us here is so vital, and what I'm always a proponent of, because my entire career has been with optometry and ophthalmology co-managing so that we can maximally treat the number of patients required. Like Man was sharing, my background is I am an OD from the Illinois College of Optometry, so I believe just down the street from Dr. David Ramsey. And I have an MPH from the University of Alabama in Birmingham. So it is my honor to get to introduce both of you. The accolades for each is very large, but let me try to shorten it. First, I will introduce Dr. Mahesh Bhardwaj, who obtained his optometry degree, his OD, from New England College of Optometry. He was clinical instructor of ophthalmology at Tufts Medical School for 20 years. He did his clinical training at the Joslin Diabetes Center and the Lahey Hospital. Dr. Bhardwaj is adjunct professor at the New England College of Optometry, where he educates fourth-year interns. So such a privilege to have him with us today. And now, Dr. David James Ramsey. Again, the list of degrees is very long. Let me try to name just a few. Sir, I believe you are a Bachelor of Arts from Harvard College. Everybody knows where that is. An MD as well as a PhD from the University of Illinois College of Medicine in Chicago. And then as well, an MPH from the Illinois School of Public Health in Chicago, followed by trainings at Wilmer Eye Institute of Johns Hopkins and the Massachusetts Eye and Ear Infirmary. And I just have to show, this is always on my book, always on my desk. So even now, this is my cheat guide. It's the Mass Eye and Ear Manual that I have had for 20 years. And if it fit in my white coat, I would keep it there all the time. So for both of you, it is an honor and a privilege to have you with us today to share your wealth of knowledge. So I welcome you both. Thank you.
Thank you. Thank you, Dr. Gupta, for your kind introduction. Hi, everyone. I'm Dr. Mahesh Bhardwaj. It's my pleasure to talk to you today. I hope you are all doing well during this pandemic time. Next slide. We dedicate this lecture to Dr. Li Wenliang. He was an ophthalmologist from Wuhan, China, who sacrificed his life to inform the world about coronavirus. Course objective is to screen patients at risk for developing diabetic retinopathy. It's a collaborative approach between the patient, the primary care physicians, and retina specialists to encourage and provide lifelong care. I'm going to talk about diabetic retinopathy. Then Dr. Ramsey, our retina specialist, will talk about different staging of diabetes and treatments. And then we are going to talk about telemedicine to improve screening and monitoring. We have done one international project about telemedicine. And right now, during this epidemic, telemedicine we are using on a regular basis. Diabetes mellitus, which is a global health issue. It's nearly 1/3 of population of the United States have diabetes or pre-diabetes, almost 100 million people. More than 30 million, 9.4% have diabetes in the United States. Complication of diabetes can categorize into two categories. One is macrovascular, heart attack, stroke, peripheral vascular disease that can cause amputation, microvascular, neuropathy, nephropathy, kidney problems, and retinopathy. This we will concentrate on. In India, 73 million or 11.8% of adults have diabetes. The prevalence of diabetes have stabilized in the last 4 years, according to the Indian National Diabetes and Diabetic Survey. Variation is prevalence in northern part of India and southern part of India. Diabetes is more prevalent compared to west and east. I bet it's due to some food or sanitary habits. Diabetes in India, Indian individuals have a high predisposition to type 2 diabetes mellitus, which tends to develop at a younger ages, and they have lower body mass index than in Western countries. So they are thinner compared to Western people, where they are a little bit overweight. They tend to have a high risk of coronary artery disease and possibly a low risk of microvascular complication compared to white individuals. So they have less microvascular complication compared to people in the western part of America. Since the 1960s, the prevalence of diabetes mellitus in India have increased in both the urban and rural areas of the country. The reason behind that is that people are eating a lot of fatty food and they are not doing exercise on a regular basis, and it varies in socioeconomic state. Risk factors for diabetes and pre-diabetes. Age, most often, the older you are, the more risk of diabetes you have. Diet, especially if you're eating processed foods, which is high in fats and sugars, people develop more diabetes. Obesity is a big risk factor for diabetes. Physical inactivity, people are not doing any exercise on a regular basis. They're not walking. If you walk 30 minutes, 5 times a week, you can reduce your chance of developing diabetes or diabetic retinopathy. Smoking, a lot of people, they smoke. We tell people not to smoke because smoking can make diabetes worse. High cholesterol and triglyceride, people have high cholesterol and triglyceride that can make diabetes worse. Hereditary, unfortunately, we cannot change. First degree relatives, parents or siblings with diabetes. History of gestational diabetes in ladies, when the woman, they are pregnant, then diabetes can get worse. Types of classification of diabetes. Type 1 is autoimmune, where pancreas not producing enough insulin or no insulin at all. Type 2 condition that affects the way body processes sugar. Gestational diabetes, it occurs during pregnancy, and it's very rare. Maturity onset diabetes of young MODY refer to any of the several hereditary forms of diabetes mellitus caused by mutation in an autosomal dominant gene disrupting insulin production. So we can do blood tests to detect diabetes, fasting plasma glucose. You have to tell the patient to avoid food and drinks for 8 hours. They can drink a sip of water. Normal is less than 100 milligram per deciliter. Pre-diabetic is 100 to 125 milligram per deciliter. Diabetes type 2 is more than 126 milligram per deciliter. That's a very common test we use to detect diabetes. The second one is glycosylated hemoglobin A1C test. It tests the average blood glucose level over the last 2-3 months because the red blood cells, they last for 3 months. Normal A1C is below 5.7. Pre-diabetic patient, they have 5.7 to 6.4% A1C, and diabetic patients have A1C of more than 6.5. The third test is oral glucose tolerance test, which is still used in pregnancy. Person has to fast overnight at least 8 hours, but not more than 16 hours. Blood glucose is tested at baseline, and then 2 hours after drinking glucose at a sweet, they have to drink a sweet tasting liquid. So normal is 140 or less milligram per deciliter. Pre-diabetes, 140 to 199 milligram per deciliter. And the type 2 Gestational, they have over 200 milligram per deciliter. Each year, 5 to 10% of people whose test result shows impaired glucose tolerance, actually they develop diabetes. So weight loss and exercise may help return glucose tolerance to normal. Worldwide, it's an epidemic. It's 422 million people have diabetes. Leading cause of visual impairment in working age adults. Nearly half of them they go undiagnosed. So diabetes is on the high rise, and diabetes is increasing in modern society. Screening type 1, type 2 diabetes. People with type 1 diabetes should have an annual screening for diabetic retinopathy beginning 5 years after the onset of diabetes. People with type 2, which is more common, we have 90% of the people have type 2 diabetes. They should have a prompt screening at the time of diagnosis because they can have diabetic retinopathy at the time of diagnosis because they don't know how long they have diabetes for. Women with diabetes who become pregnant should be examined early and closely in the course of pregnancy because retinopathy can progress during the pregnancy. So generally we recommend first trimester. If they don't have any diabetes, they can be screened in 1 year. But if they have diabetes and they have moderate non-proliferative diabetic retinopathy, then they should be seen in 3 to 6 months. Diabetic retinopathy, modifiable risk factors. Both clinical trials and epidemiological studies have shown that two key modifiable risk factors associated with diabetic retinopathy are blood sugar and blood pressure control. So those two things we can control by doing exercise, by eating healthy food, by decreasing the salt intake to reduce the blood pressure and reduce the blood sugar by eating less sugar and less fatty food. The prevalence of retinopathy strongly correlates to both the duration and level of control. If you control your diabetes, you have a better chance of not developing bad diabetic retinopathy. Maintaining near normal glucose levels and near normal blood pressure lowers the risk of retinopathy developing and progressing. Lesser impacts from diets, micronutrients, triglycerides, cholesterol, and other factors. Diabetic eye care includes a medical history, a comprehensive ophthalmological examination. We screen with high retinal photographs of patients who have not had previous treatment for diabetic retinopathy or other eye disease and regular follow-up. Medical history is the key because if you don't ask them questions about their medical history, you will never know what's going on. You have to spend a few minutes with the patient asking their symptoms because you will notice that sometimes they will come to us and they will complain of blurry vision, sudden onset of blurred vision in a younger patient. So we think of blood sugar. So we order blood test and then we find out they have diabetes. So anybody in optometry office, if they come in, they complain of sudden blurred vision, they should think about diabetes. Only 50 to 60% of patients with diabetes are screened annually. So 40% of the people are not even going to optometrists or eye doctors. So they should be informed that they should see their primary care doctor or optometrist or ophthalmologist. Currently, recommendation is screening for diabetic retinopathy is 1 year. If they don't have any diabetes, diabetic retinopathy, we see them every year. If they have diabetes, diabetic retinopathy, if it's mild, we see them in every 6 months. And if it's severe, then they have to see our retina specialist, Dr. David Ramsey. So diabetic retinopathy, we can screen by direct or binocular indirect ophthalmoscopy, slit lamp microscope with 78 and 90 diopter lens. Here's the slit lamp picture. And retinal photography is very important because sometimes you are doing a great eye exam, but you can miss some dot hemorrhages or microaneurysm, vice versa. Gold standard is a visit to ophthalmologist or optometrist. We have to do comprehensive dilated eye exam with a refraction because in my practice, I've been practicing for 25 years at the Lahey clinic where I've seen a lot of patients, they come to me and they complain of sudden onset of blurred vision. And I noticed that once we order blood sugar, they have diabetes. So I refer to PCP, primary care physician, so they can see them and they can control their diabetes with medication. And the most important thing is you have to communicate with the patient the primary care doctor, the most important, then the patient will trust you. Side effects, comprehensive dilated exam, often with the refraction. So refraction is the key because all the optometrists all around the world, we are doing refraction on a regular basis. So if you see any patient who has blurred vision, sudden onset of blurred vision, if they are older, you think of cataracts too, because cataract can cause myopic shift. But if you are seeing a healthy 30-year-old, 40 years old, sudden onset of blurred vision, you always think of checking their blood sugar. Dilated eye exam is very important because without dilation, you cannot screen for diabetic retinopathy. And we educate the patient at the time of dilation that their vision will be blurry. We will dilate them with tropicamide, which is a pharmacological it affects the sphincter muscle of iris, and then phenylephrine, which is a sympathomimetic agent, which stimulate the dilator muscles, and their vision will be blurry for 6 to 8 hours. And we provide them with sunglasses, or they can come with a driver because their vision will be blurry for 6 to 8 hours. That's the best exam to screen for diabetic retinopathy. Gold standard for photographic screening for retinopathy, we use 7-field stereoscopic fundus photography. That's of 30 degree. You can see in the background black circles. That's the 30-degree view of the fundus. Then ultra-wide optos retinal images, which is expensive, and they can give you can see the middle of that is 50 degree compared to 200 degree we get with the optos. Non-mydriatic, portable, handheld fundus cameras have been developed, does not require dilation of the eye, can be used broader range of providers. They can be used by primary care doctors in their office, by medical assistant. They can use at our pharmacy stations. Studies have validated compared to both gold standard in and in-office ophthalmoscopy, and can be placed in different remote to the eye clinic, primary care offices and pharmacies. And now Dr. Ramsey will take over the presentation, and I will introduce you to my friend and great retinal specialist, Dr. David Ramsey.
Thank you, Dr. Bhardwaj. It's very nice to see everyone here today at this webinar, and thank you very much for the opportunity to speak. Dr. Bhardwaj has done an outstanding job of introducing the diagnosis of diabetes, as well as the important steps to screen for it. Now we're going to talk a little bit more about the signs and stages of retinopathy so that optometrists and ophthalmologists can speak the same language when it comes to diabetes. The classification of diabetic retinopathy progresses from mild to moderate to severe non-proliferative disease, and then on to the proliferative forms of the disease. In the mild non-proliferative diabetic retinopathy, pretty much the only finding that should be expected to be observed are small outpouchings of the small capillaries known as microaneurysms. In moderate disease, some of the other more prominent features of diabetes begin to be seen, such as exudates, hard exudates, soft exudates, dot and blot hemorrhages, or cotton wool spots. And in the severe non-proliferative form of the disease, we begin to see extensive dot blot hemorrhages in all quadrants, venous beading, intraretinal microvascular abnormalities known as IRMA, and extensive cotton wool spots. Table 1 shown here from the American Academy of Ophthalmology Preferred Practice Patterns illustrates the different stages in our diabetics, from no apparent retinopathy, where no abnormalities are typically observed on a routine, comprehensive, dilated eye exam. This doesn't mean that there aren't abnormalities, and if additional tests were to be done, though they're not indicated, one might find early signs of diabetes, but basically these patients have no overt signs of retinopathy based on exam by a qualified eye care professional. Mild non-proliferative diabetic retinopathy microaneurysms are seen. Moderate, as stated, is more than microaneurysms. So you begin to see the other features mentioned. And then for severe non-proliferative diabetic retinopathy, we have both a US definition and an international definition. In the US, we tend to follow a little bit stricter criteria of the 4-2-1 rule, where we have severe intraretinal hemorrhages in all quadrants, definite venous beading in 2 or more quadrants, and at least 1 intraretinal microvascular abnormality. The international definition typically is one of these features is enough to qualify as severe NPDR, so a lower threshold for this definition. Proliferative diabetic retinopathy is marked by prominent features and changes such as neovascularization, where abnormalities in the retinal vasculature, new vessels begin to grow, not within the retina, but on top of or into the vitreous cavity. And very commonly, these new vessels are very fragile and prone to bleeding, and they can lead to vitreous or pre-retinal hemorrhage. Proliferative retinopathy can then go on to scar and fibrose and cause retinal detachment and further evidence of blindness. The reason why these different categories are important, as you already heard Professor Bhardwaj discuss, is that depending on the category of disease, it guides our timing as to how often they need to be seen. And based upon other demographic and risk features, we tend to see those patients without apparent retinopathy every 1 to 2 years, mild retinopathy every 6 to 12 months, moderate retinopathy typically every 6 months, and severe non-proliferative forms of disease, depending on the severity and the rapidness with which it's progressed, as frequently as every 1 to 3 months, and proliferative retinopathy very much the same. And then from the level of treatment by the ophthalmologist or the retina specialist, based on the category of disease, different degrees of disease will merit a different threshold for treatment, and we'll touch upon that. In order to have a standard way to talk about disease, it's important for optometrists and ophthalmologists to be on the same page when we observe different findings and features. The standard photographs from the ETDRS study are one way that we can all be on the same page for identifying the various features of diabetes. And I point out to you here a few of these historic photographs that are useful for allowing us all to speak the same language. Standard photograph 2A is a key photograph to illustrate dot and blot hemorrhages, which are shown here as the red streaks, and the little tiny microaneurysms, which are numerously present within this standard photograph. Intraretinal microvascular abnormalities are these small abnormalities that occur within the substance of the retina. The standard photograph 8A is able to illustrate for us a moderate IRMA. This moderate IRMA is seen best, of course, in stereo. In stereo, it would appear flat, as opposed to proliferative disease, where new vessels tend to rise up and off the surface of the retina when we look in 3D, either with our indirect ophthalmoscope or best yet our slit lamp biomicroscopy. Venous beading, shown here in standard photograph 6A, demonstrates these outpouchings and changes with the engorgement and beading along the veins within the eye. In this particular photograph, the two main branches of the temporal vein shown the beading, which is present and definite, but not severe. It can be quite a bit more extensive than this. And finally, neovascularization, new vessels which rise up and off the retinal surface, commonly at the disc as shown here in standard photograph 10A, but can also be seen as new vessels elsewhere within the retina, commonly along the arcades and prominently often in the mid-periphery. And then most importantly, diabetic macular edema. Shown on the right is an illustration of my normal right eye and a normal macula in panel A above. And below that, clinically significant macular edema as illustrated by the diabetic photograph shown in the bottom right, and so-called center-involving macular edema as is best illustrated with what's known as optical coherence tomography. This OCT demonstrates a cross-section through the retina that shows the characteristics cysts of fluid or pseudocysts of fluid that occur within the retina of the diabetic, the so-called swelling and leakage that occurs and is the cause of the majority of vision loss for our patients with diabetes. Clinically significant macular edema has historically been defined as thickening of the retina within 500 microns of the foveal center, hard yellow exudates at or within 500 microns of the center of the macula near the fovea with associated adjacent retinal thickening, or one or more zones of thickening, at least one disc area or larger, in any portion of the thickening is within 1 disc diameter of the macula. Clinical trials have demonstrated that anti-VEGF treatment is very effective for treating this, and most trials now utilize OCT rather than stereoscopic photographs or clinical examination to follow and guide the treatment of macular edema. But of course, in our practices, we don't always have access to OCT. It's a wonderful tool if you have it, but it's possible to use our clinical examination and this more historic definition to allow the coordination of care for patients who have vision-threatening macular edema to know where and when to refer them to the ophthalmologist or retina specialist. Treatment of diabetic retinopathy is now primarily threefold, as has already been introduced. Intravitreal anti-vascular endothelial growth factor agents are effective in the treatment of center-involved diabetic macular edema associated with vision loss. Intravitreal injections are also now increasingly being used to treat proliferative retinopathy. That's a topic for another discussion, and it's debatable whether that is an appropriate treatment in all settings, but we do have some of our patients now receiving intravitreal injections for both center-involved diabetic macular edema as well as proliferative retinopathy. Laser photocoagulation remains the preferred treatment for non-center-involved diabetic macular edema, and panretinal laser photocoagulation remains the mainstay of treatment for high-risk proliferative diabetic retinopathy. In certain cases of severe non-proliferative diabetic retinopathy in certain demographics, we also rely upon panretinal laser photocoagulation to protect and conserve the vision of our patients. And finally, as a vitreoretinal surgeon, vitreoretinal surgery is reserved for the most advanced cases, including vitreous hemorrhages, which are slow to clear, and of course, the nemesis of our diabetics, the tractional detachments that occur from scarring and proliferative disease. These can be amongst the most difficult and longest cases that we as retinal surgeons tackle, but the results can be good and vision can be recovered with surgery. The agents that block the cytokine VEGF, there are 4 main family members that are in use, 3 of which are used commonly now and 1 uncommonly. The first, pentaganib, a small aptamer, ranibizumab, a humanized antibody fragment, aflibercept, a VEGF trap, and bevacizumab, a humanized monoclonal antibody used commonly off-label for the treatment of diabetic eye disease. At the Lahey Clinic, we rely primarily on bevacizumab Avastin due to its reliability, its easy access, and its low cost compared to the other agents. But we find great efficacy with the ranibizumab, and in certain patients with very resistant disease, aflibercept appears to be a somewhat better drying agent. Importantly, from the DRCR network, with rare exception, ranibizumab, aflibercept, and bevacizumab are largely equivalent, and in real-world application, they're about equal in their ability to treat and manage retinal disease. For patients that have resistance to anti-VEGF agents, there are a subset of patients where we can inject steroid into the eye, and that steroid can complement the treatment with anti-VEGF agents in some patients as well. But of course, injection of intravitreal steroid is with a higher incidence of side effects, including the progression of cataract for those patients that remain phakic, and also importantly, a risk of eye pressure problems. Now, Dr. Bhardwaj and I would like to transition on to talk a little bit about teleophthalmology. This is very much the future of ophthalmology, and in the recent epidemic of COVID-19, it appears that utilizing technology and tools to screen and manage our diabetics more efficiently may become ever more important. Telemedicine model for diabetic retinal disease. Diabetic retinopathy may be asymptomatic for years, even in advanced stages, so screening using new technologies such as telemedicine is essential to identify, monitor, and guide the treatment of retinal disease. The way this works most effectively is remotely images are required, depending on the circumstance at the site of a primary care office, a community health center, or off in the community. These images are then transferred to a centralized location for evaluation by qualified eye care providers. Optometrists such as Dr. Bhardwaj and myself, a retina specialist, often read these images and help each other to identify retinal disease. And in the future, although in cases where it is available, artificial intelligence may help and read these images. Right now, we still, at least in our setting, primarily do all the reading manually. Finally, these findings are put into the medical record, and these findings are communicated back in the form of letters to patients and communication to the primary care physician or community health workers to guide the future treatment and care of the patients with diabetes. Importantly, research has shown that current diabetes and eye treatment combined with telemedicine can reduce the incidence of diabetic blindness by as much as 95%. This can be a very effective and importantly cost-effective method for reaching our patients with diabetic eye disease. The Beth Israel Lahey's current state, we have 5 sites which we have fully equipped with non-mydriatic portable fundus cameras and software, and we're bringing online, although this has been interrupted recently by the COVID epidemic, 2 additional sites in the near future. These cameras, which are the best available for us, cost around $11,000 each, and although there are many companies that make these devices, they all are roughly at this price point now. The program to date has been completely funded by grants, and we've been able to extend our ability to reach primarily patients who have been non-compliant with the eye exam. Stepping back, worldwide, 50 to 60% of patients are not compliant with eye screening, and roughly as many as half of patients don't even know they have diabetes. In the United States, those numbers are not quite so bad. Only about a quarter of patients may not know they have diabetes, but still 40% of patients or more may not get diabetic eye screening, even in the case where they know they have diabetic eye disease and have been coached by their primary care physician. The project which we've rolled out at Lahey is primarily designed to capture those patients who have difficulty taking time off of work or making it into the eye centers for screening, and it provides an important piece of care in reaching these patients who are otherwise unable to effectively access eye care. Here's an example of one such patient. It's a 52-year-old male with a 15-year history of diabetes, an A1C of 10.1 in this particular case. This is a patient who's been non-compliant with diabetic eye exams. He has not come in for his annual eye checkups because he has no complaints. He doesn't see the need. At his primary care office, he received photographs using one of our portable cameras. His vision in the right eye when he came into clinic following the screening was 20/20 and 20/25 in the left eye. So together he's, again, asymptomatic, but we see that he has retinopathy of a mild to moderate state, or as we like to say in our program, more than mild retinopathy. And we see he has exudates tracking toward the fovea. He has what appears to be macular edema with these photographs taken with our non-mydriatic camera. And then when we bring him into the clinic, we see when supplemented with an OCT that he has center-involved diabetic macular edema. Now, importantly, this patient with good vision doesn't necessarily need treatment at this point, but it's very important to identify a patient who is at risk of vision loss. This is a working age individual. If he begins to lose vision in one or both of his eyes, he may lose the ability to work or work as effectively. And knowing that he has vision-threatening macular edema means that we need to watch him more carefully and provide the important points of education and prepare him perhaps to receive intravitreal injections in the future. If this disease is to worsen or his vision were to deteriorate, the standard of care for this patient would be intravitreal injections. That's difficult for many patients to accept. Partnering with our optometrists to continue monitoring ever more closely these patients, coordinating with our retina specialists to prepare them for possible future injections is very important to allow us to effectively be able to manage and treat these patients. So our teleophthalmology program at Lahey, its mission is to bring value to the physicians, patients, and Lahey organization as a whole. We provide value to patients as we provide an effective alternative to traditional face-to-face screening. Although it is not better than an in-person eye exam, it does provide a necessary level of care for certain patients who have not access to eye care. And by virtue of this program, we begin to build the relationship so that we can begin to bring these patients who are otherwise sometimes non-compliant in to see our expert optometrists and other eye care providers in order to watch over them. We provide better value for our caregivers, and by virtue of this program, enhance our access to eye care, and thereby, as we capture patients at risk of vision loss, enhance their quality associated quality of vision. Preventing vision loss is priceless. And finally, we provide value to the organization. This is increasingly a service which is reimbursed, and although it does not generate as much revenue for a health system as providing gold standard eye care, it does provide a cost-effective way of reaching these patients, and as insurance increasingly reimburses for this, for those patients for who it's indicated, it actually could be a more effective and cost-effective way of delivering care in a relatively low-risk population of individuals. Next, I'd like to hand it over and back to Dr. Bhardwaj to share a little bit with you about the Sophie Manawi Eye Screening Program. This is one of our international endeavors that we've worked with in partnership with many others. And Lahey for this program was the reading center for images taken with a non-mydriatic portable fundus photographic camera. This is a high-risk population of Samoans with diabetes that were screened with this device. And I'll turn it back over to Dr. Bhardwaj to tell you a little bit about our accomplishments with this program.
Thank you, Dr. Ramsey. Samoa, as you can see in the map, there is a small isolated population in the South Pacific. Samoa is like a very high risk for diabetes because 50% of Samoan adults have diabetes and 80% are overweight or obese. Glucose monitoring is very difficult due to limited equipment and uncertain supply chains due to geographic location. It requires that all care is received in Samoa with only one-time full ophthalmologist, currently serving at a population of nearly 200,000 people. So it's very difficult for them to get an eye exam. To determine the percentage of clinically gradable images that could be obtained using the panoptic eye examiner system, a low-cost handheld non-mydriatic fundus camera we use for the screening there. The panoptic, similar to handheld direct ophthalmoscope, it provides a 5 times more larger view than direct ophthalmoscope. So it provides you 25-degree versus 5-degree for the direct ophthalmoscope. 206 subjects were screened between June and August 2018. 2,758 images were obtained from 337 eyes. On number A slide, you can see it's a healthy fundus. It's a little bit out of focus. And number 2 is B slide that has mild dot hemorrhages there. It's called non-proliferative diabetic retinopathy. And third, you can see, look at the optic nerve and you can see the cupping. The cup is large and that's we identify as glaucoma suspect. Positive findings identified in 29% of 29.1% of participants, moderate non-proliferative diabetic retinopathy detected in 3.4% of the participants. Additional findings in 18% of participants included glaucoma, tumors, or other structural abnormalities were seen during the screening. Future of teleophthalmoscopy is less expensive, more convenient image devices, more readily available. It improves portability and quality. Its collaboration with community health provider and specialists. It increased patient participant in the surveillance. Conclusion is you have to tell the patient to follow a healthy diet and healthy lifestyle to reduce the chance of diabetes and diabetic retinopathy. So they have to eat less fatty food. They have to decrease the salt intake. They have to do exercise on a regular basis. They have to take a brisk walk 30 minutes for 5 days a week. Promote medical management on the underlying diabetes. So they have to see their primary care doctor to treat diabetes. They have to take medication on time. Provide timely ophthalmic evaluation. We refer to retina specialists or ophthalmologists when there is evidence of diabetic, moderate to severe diabetic retinopathy. Generally, mild to moderate, I generally see on a regular basis, but if it's severe and non-proliferative diabetic retinopathy or proliferative diabetic retinopathy, we refer to a retina specialist. And I have a privilege to work with Dr. Ramsey, who is such an excellent ophthalmologist. And treatment under the care of an ophthalmologist or retina specialist, laser, anti-VEGF agents, or intravitreal corticosteroids. The most important thing is effective communication and care coordination is necessary to control diabetes and diabetic retinopathy. So communication is the most important concept. If you see a patient, you talk to them, you explain it to them, what are the advantages to control diabetes, They will listen to you because you spend quality time with them. Optometrists have more time with the patient because they spend more time. So if you can communicate with your patients about controlling their weight, about blood sugar, they will reduce the chance of diabetic retinopathy.
Excellent.
And thank you for listening to us, and stay healthy. And please ask any question if you have, we'll appreciate it.
Thank you so much. In fact, it was fully engrossed in the session today. I would request the panel now to come forward, and we can have the screen sharing been there. Let all be there. Ajit sir, Rajesh sir, and Dr. Sumit Grover. Dr. Sumit Grover would like to hear from you. Whatever has been said, I feel is quite doable in India. And the model, can we have similar kind of model in India to take it forward?
First of all, I would like to thank Dr. David and Dr. Bhardwaj for such a comprehensive and wonderful presentation with so much fluency, clarity, and discretion. Thank you so much, sir.
Thank you.
And as far as the few points from the presentation is concerned, I would like to highlight for the students, with the permission of Natarajan sir, with the presence of legends like Dr. Sundaram Natarajan here, I would like to start with his permission, because he is our teacher, the leader of ophthalmology in India, the retinal surgeon. So with your permission, sir, I would like to highlight few points from the presentation for our optometry students, that it was discussed that you are the primary eye health care providers. So you have a privilege, an opportunity to spend more time with the patient. You can talk with the patient much more than a busy ophthalmologist. So the onus is on you. We have to make our standard protocols that whenever a patient of diabetes come to our optometry clinic, we should spend some time and make a rapport with the patient, ask for their history, that duration of the diabetes is very important, and what medications are they are on, like what is their glycemic control is like. So these things are very important, and you can counsel them on because it's like a lifestyle modifiable disease. So this is very important. Other thing about the classification, this thing which Dr. David explains very much diligently, that we have to be on the same page if we are managing or co-managing a patient. So you have to be well versed. We all have to be well versed with these classifications, because classification may differ. Like preferred practice patterns in United States are maybe slightly different, and then UK, they follow the national NSC classification, National Screening Committee, and we have various very nice guidelines from AIOS and VRSI, etc. So we have to be very well versed, so that when we communicate with an ophthalmologist after grading and taking the images, so there should be no confusion and there should be a better coordination. And the most wonderful thing I learned from this presentation from Dr. David was the telemedicine screening. It's a win-win, how it's a win-win situation for the patient, the caregivers, as well as the institution. Like for the patient, it's an effective alternate to the face-to-face this thing, so that in India we know that many of the population, they live in a rural area. So we as a public health ophthalmologist, I have that this thing now. I have instilled this in mind, that we have to take everything into account, that the out-of-pocket payment of the patient, which he spends from coming, because all of the basically the centers, which are tertiary care centers, are in the centers. Especially I'm talking about the northern part of India. In the south, the Arvind, the Shankara Netralaya, LV Prasad, they have done a wonderful job by making a healthcare pyramid to the vision centers. But in north, they are like the major centers are in the city centric. So if we go for telemedicine, we will make people life easier, and there will be less economic burden for them. And it's a win-win situation for the caregivers also to have to increase their capabilities, and for if we make a balance between altruistic goals and the self-serving goals, then the program can be sustainable. And I'm looking forward to many projects, like since Dr. Natarajan took the leadership of AIOS as a president. I know that under the Aditya Jyot Twinkling Eye Foundation, Jyot Se Jyot Jalao, he has been revolutionized the diabetic screening, and we have so much to do, and there is more and more potential. And as we know, Professor Monica at Ansel University, we use the Remedio camera for our students, and we know that our students take wonderful pictures. Being a first, second year optometry training, they use the camera so well, and there is many things to, but we are still on the learning curve. And I believe that under the able leadership in India, and learning from the leaders like Dr. David and Dr. Bhardwaj, there is a long way to go. And I would like now to listen a few wisdom words from Dr. Natarajan. Sir. Dr. Natarajan, sir.
Like we did in HIV, we will speak only in the back. We need at the center of the messaging.
Yeah. Hello. Yes.
Yes, sir.
Yes, Sumit. Yeah. You asked me something.
Yeah, I told I requested you to just complete the session by making your expert opinion about the expansion of telemedicine under Jyot Se Jyot Jalao, this thing, sir. You have revolutionized the concept of DIA screening in India, and
Yes.
under your able leadership, I think AIOS and India has a long way to go under telemedicine, and we can learn from the models of as suggested by Dr. David and Dr. Bhardwaj, that how the telemedicine in their setup is very sustainable, and it's beneficial to the caregivers as well as the patients. And I think in India we have a long way to go, sir, as well.
Yes. No, I'm thankful to all of you. I think it was a wonderful presentation covering from the basics of diabetes changes, and then to the advanced treatment, and then how optometrists and the retina specialists working together. I think, and that's what I think has to be a certain example. And I'm only adding the social worker or the other innocent people in the group, so that who are not in the group, but I think we'll be able to join this in this crusade against diabetic blindness. And already I've got the academic and research committee. Then we have our own Retinal Society of India, and now we have Optometry Association. I think all of us have to come together and make this. And I already told my group, the Aditya Jyot Optometry and Aditya Jyot Optometry, that only a hybrid model is the only way to go. And thankful to Mr. Ajit Bhardwaj, who mentioned about in that previous webinar, and today Dr. David and both Mr. Bhardwaj mentioned about how we can do. I think we have to find a way, and we have to reach everybody's home and get telemedicine, teleophthalmology reaching every home in India.
Thank you so much, Dr. Natarajan. And I believe we will now take up questions also to bring in, but it is the fact that the optometrist does not even need, it's not only the retinoscope that he needs to invest in, it's an ophthalmoscope or a 90D lens or even the cameras. And I think the discussion next we can talk about is cameras. We're looking at a low-cost investment also here, so that every optometry clinic one day would have a retinal camera, and it becomes a part of his refraction, which what we see is happening in US. So Dr. Mahesh and Dr. David, can you tell us one thing? Suppose an optometrist misses out the diabetic retinopathy or a glaucoma suspect. Are there legal laws against that or something, some action against the optometrist if he misses that in the screening?
I'd be happy to answer that question.
Sure,
There's,
sure. Thank
in
you.
our country, there is always a risk to the practice of medicine. And no doctor or exam is perfect. There's always the chance that as a busy optometrist, ophthalmologist, or retina specialist, that something will be overlooked. And of course, it depends on whether or not harm comes about as a result of that. So although something may be missed and that could, make someone upset, it certainly disappoints the doctor when we do not see something that we should see, to warn and educate our patient. This is one of the reasons why it's so important for there to be repetition. The patient comes back for an exam every year or every 6 months. This will give the opportunity for both the patient and the doctor to each themselves not miss something, because it's as equally the case that we as an eye care provider may provide information to a patient, and the patient may not assimilate or take in that information, or for that matter, take it to heart. So there can be liability, but that's certainly not a reason to not screen. And it really is not a significant consequence unless there's harm that results. Take, for example, a patient with either no retinopathy or very mild retinopathy. The reason why we do these screenings and do them on a regular basis is because there's a probability that that patient will go on serious or vision-threatening disease. That risk in a patient whom we've even screened negative appropriately is still somewhere between 1 to 5%. And does it mean that that patient who's in that 1 to 5%, does it mean that the doctor missed something? Or does it mean that that patient simply had bad luck, a bad outcome, something happened down the road? It's not possible to always second guess ourselves. We simply need to always do the very best that we can for our patient and for our fellow eye care professionals to deliver the highest standard of care so that the outcomes as a whole are as good as they can be. There's always going to be some outcomes that are not exactly the way we would want them to be. But the reason why we have these screening protocols in place is to do our very best, to do our best for all our patients.
Thank you. Olinla, would I request you, Ollie, if you have questions, we can take it up. Ajit sir, you like to add in your insights a little later or now?
Well, I'll chip in a bit.
Sure. Yes, please.
Listening to interesting presentation by Mahesh and Dr. Ramsey, I just want to give you a slight background about Mahesh. Mahesh did his optometry from AIMS. He's an alumni from RP Center.
Yes.
After graduating, he took a lateral entry into New England College of Optometry in 3rd year, and now he's a professor there. And Dr. Ramsey, when I saw his name, it looked like a very Indian name to us because, it's a very famous name in India because your name, we have a lot of a Bollywood director. I don't know if you know him. And he has produced many wonderful horror movies in India. We are scared of his name. So nice to have your talk. And what I want to understand, or what I summarize on this talk from Mahesh, that optometrists have a critical role because they have time to observe and communicate with the patient. You are a primary eye care practitioner. So your job is more critical because if you observe, detect it early, you save a lot of chances that the patient will not develop diabetes and develop into a kind of sight-threatening diabetic retinopathy. So what I always tell my optometrists, be watchful. Immediately the patient enters in the clinic, you have to observe his each and every behavior. And I'm very passionate in the sense that I observe their behavior and realize that most of the time you even get to know a diabetic observing a patient from your waiting room itself. Because when a patient, I'll give you a few of the hints about it. Patient who is diabetic, when he comes to your clinic, he is kind of irritated. He doesn't like to wait. He's asking for water every 5 minutes. he comes with his food in his bag, he'll carry it because he feels very hungry all the time, and he's never happy with his glasses. So if you observe 5-6 things about his behavior, at the same time about his fitness, he will be always yawning in the clinic, and overweight, and a bit lethargic in his attitude. Observing these, and if you ask his good history, you will realize that you have identified a patient asking for his blood sugar, asking the history about it, asking for his hemoglobin checked. You will realize that you don't really need all those scientific or expensive equipment to diagnose diabetes. And controlling the diabetes by just reducing, implementing lifestyle changes helps a lot. And secondly, if you have a mid-retic, non-mid-retic camera in the clinic and tie up with a retina specialist for referrals, for identifications, it's a great kind of opportunity for optometry. And we are working extensively on telemedicine. We had a great talk just 2 days back from Dr. Sachdeva, Dr. Ritika Sachdeva, and I was impressed with the view and what the future holds from Dr. Natarajan for us, that they're so open to the idea of collaborating with optometry for telemedicine. And we are soon coming up in the next talk on 2nd of May. I'll talk to you about later. But the key is identification, communication, and taking photographs and referral. If you just follow this on a periodic eye exam, asking not the patients to delay the eye exam, and I feel there's a challenge for our retina specialists post this COVID, because I understand that many patients are not coming for the injections. And this may give a rise to, blindness related to diabetic retinopathy. So I think they'll be concerned that they need to address when things open up. And I think that's my comment for the day. And I will hand over this to Oli to take our question and answer. Thank you.
Thank you.
Thank you, Dr.
Thank you. Thank you.
And Doctor. So it's a wonderful presentation. I think you have almost answered all the questions which are raised during the webinar. A few which are left is, number one is, there was a question, why refractive error changes in a diabetic patient? If you can.
Because there is a high blood sugar and the lens absorbs more water, and because of osmotic pressure, so because of more hydration, their prescription changes. That's why the lenticular changes, it's causing change in the refraction.
Great. Coming to the next one, can you briefly explain the AV changes that happens in diabetic patient?
I think I would be best suited to address that. The earliest changes that occur within the diabetic patient are things which the diabetic patient is not able to perceive, and in fact, most eye care providers cannot see. I do electrophysiology, and electroretinographic studies on diabetic eyes show that one of the earliest and first changes that occur is a loss of the oscillatory potentials of the full field electroretinogram. This psychophysical change is not easily perceived by the patient, but advanced psychophysical testing can show that this translates into a loss of contrast and color perception of these patients. These changes are reversible, and they may or may not be direct harbingers of more fulminant retinopathy, but they are clearly the earliest changes that are recordable. Using advanced imaging techniques and technologies, including advances in angiography and OCT angiography, we can also find structural changes very early in microvascular organization, and more importantly, function. Those are perhaps the earliest physical features that can be seen within the diabetic retina. And then histopathologically, if we were to take eyes out of a patient and to actually examine them biochemically or histochemically, we can see that there are a number of neurotransmitters that change. One of the areas of work that I did very early on in my career is looking at the GABA signaling pathway within the retina. There's an abundant accumulation of the inhibitory neurotransmitter GABA, and this has functional implications that underlie some of the structural and functional changes that follow very early in the course of diabetic retinopathy.
Thank you so much.
Great, sir. Coming to the next one, if somebody, if you get retinal changes in non-mydriatic fundus cam, it is mandatory to do dilated examination before start doing the intervention or management.
Without a doubt, yeah, without a doubt, I would expect any positive findings by means of a fundus camera image to be checked by our frontline eye care providers. You know, a majority of these patients go and see Dr. Bhardwaj or other optometrists at Lahey. And a majority of the time, the findings are absolutely confirmed. But without their expertise, it would not be an effective way to gatekeep. A majority of patients who screen positive for more than mild retinopathy don't necessarily need treatment. And rushing them into a clinic which is otherwise busy for the retina specialist or ophthalmologist is not an ideal way to take care of them, because they need the expertise of the optometrist to educate and present and explain in a way that only an optometrist can effectively do. An ophthalmologist and retina specialist, we're often hard pressed for time. Our waiting rooms are busy, and we're dealing with problems that are of a different nature. So partnering with our optometrists in order to introduce and take care of our patients with diabetic retinopathy is the proper order and sequence.
So is that so that if suppose Mahesh has sent it to you, you would do the exam, and then again it goes back to Mahesh for a routine checkup, which is the annual eye exam, and then he refers. Or once it is referred to you, it is now your follow-up that this patient has to do. How is it
Yes.
so?
Oh, absolutely. So I want to compliment Dr. Bhardwaj. He'll often see things that, you know, it's possible that as a busy retina specialist, we might miss. Dr. Bhardwaj is an outstanding provider of examination and finding and detail. But in order to communicate one with the other, it's very important that each of us provide our examination, which is in its own way important because it's a snapshot in time. Things that are seen on one exam as soon as a day or 10 days later, they can resolve, they can disappear. There are things that I'll observe on examination that were not present when Dr. Bhardwaj saw the patient, whether it be a week or a month or 3 months ago. That in no way means that it's been missed. It simply means that diabetes is a serpiginous condition. It's a condition where the disease can change day to day, as is illustrated by changes in its refraction of these patients' eyes, or days to weeks to months in the amount of hemorrhaging or retinopathy that may be seen within the eye. So it's very important to repeat the examination, to allow ourselves to communicate one to the other, and to ensure that whatever treatment was appropriate before is still appropriate today before we execute that treatment.
Great, sir. Last question to Dr. Bhardwaj.
Dr. Bhardwaj, I would request you. So, sure.
Yeah, the last question
Yes,
for the day. How do you see a vision rehabilitation scope for optometrists in the management of diabetic retinopathy patient?
If we see patients, they have very poor vision because of the neovascular glaucoma or proliferative diabetic retinopathy, and their vision is less than 20/200, we prescribe low vision aids. We prescribe handheld magnifiers, stand magnifiers. It is about people, they have lost their vision because of bad diabetic retinopathy. But if their vision is 20/40, 20/30, we generally prescribe regular glasses. We might have to increase the magnification for reading for them if they want to read, and they can get more magnification so they can see better. So we go with it depends on their sight. What is their sight? If their sight is poor, then they have to get low vision aids, you know.
And that's also a part where the optometry is involved. I think I would request Rajesh Wadhwa to come in because he's an independent optometry practice. And what question keeps coming into the mind, and what I see some of the questions coming up is the young ones who are planning to open up their clinic, what all should be the minimum equipment they should see so that they can, sometimes ophthalmoscopy may not be a perfect thing. You may even need an imagery to forward it to the retina specialist. So even if Rajesh or Ajit sir can bring in that point, what should be the minimum kind of equipment we look into it, and how do we mold? So what is in US and how do we see it in India? What can be purchased at a minimum cost?
See, when I used to practice in India, I had a trial frame and trial lenses. That's all I used. And I used to work. I saw my brother Ajit, who knows me because he was my senior. So we used to work with trial frame and trial lens. We never had phoropters. So I came to America. I went to New England College of Optometry. For the first time in my life, I was working with phoropters. So it's an expensive instrument. So you have to get phoropter, or you can just do trial frame. But nowadays in India, we have phoropters. We have trial sets. We have trial frames. We have slit lamp. We need a slit lamp. I think 78 diopter lens is very good.
Yes.
And I don't know whether we can use diagnostic there or not, because here we can use diagnostic agents. So there you have to get a camera which you can use for non-mydriatic type, where the patients are not dilated if you are not using diagnostic agents. And in India, telemedicine is so important because you can screen for cataracts by telemedicine, because a lot of people have mature cataract. And so you can definitely see the pupils, and the pupil will be white, and then you can detect cataract and you can refer to ophthalmologists. So this way, the ophthalmologists from their busy practice, they can see these patients and they can send you back after the treatment. So there are a lot of things, but if you can dilate a patient, then you will definitely need 78 diopter lens and 90 diopter lens and indirect ophthalmoscope. But if you are not doing that, then you don't need it. So slit lamp, direct ophthalmoscope, and non-mydriatic camera, those are the three things I think you need.
Thank you so much. And I think we would sum up because it's a Sunday morning beginning for you. And Ajit sir, you'd like to sum up before we close it?
Monica, before I do that, I would like to, I heard Dr. Ramsey telling that, they are using they're using the manual procedure for the time being. But what I want to know from him is, what is the future of, I understand that FDA has approved these two technologies or two softwares, which are, one is called IDXDR and other is Retina AI. So could you highlight how it is going to change the practice of retinal or diabetic retinal, diabetic retinopathy in investigation and its management? So could you highlight about these two software developments on?
Yeah, so we at Lahey Hospital, we have artificial intelligence software as well in the research and development stages, but the software that we're using is not yet FDA approved. The introduction of a diagnostic aid is likely to enhance our ability to expedite the analysis and reporting of findings to both doctor and to patient. But really, the advantage of artificial intelligence is not that it's inherently better than a well-trained ophthalmologist or optometrist reading images, but that it's faster and that it'll take work off of our plate to allow us to spend more time on the important matters of communicating and interpreting findings for both doctor and for patient. So it's going to be an aid to allow us to do more in the same amount of time. It's not going to replace us. It is not a threat to our livelihood. It is something that is going to only make the doctor more valuable, not less, because an artificial intelligence program may find something, but it will not be able to put that in context for the patient or for other members of the healthcare team.
Thank you so much.
I
think Dr. Natarajan has something to say, to add into this. Ollie, can you unmute Dr. Natarajan, please?
Yes, yes.
Hello. So thank you, David, for your beautiful answer given a question by our Ajit. So I think we have published the offline AI in JAMA Ophthalmology last August, and I think Alvin Liu from Johns Hopkins have written a nice remark. So we are actually using that in India, and Johns Hopkins is planning to do a trial with that. And I hope you can also think about it. You can refer the August JAMA Ophthalmology, which was the top 5 in the last year. And we are also, I think it's still not FDA approved, but that camera used by Remedios FDA approved, but not the AI, offline AI. And I think so far, the two technology which is approved by FDA is online. You need to be online. You need a cloud support for AI. Here in India, in villages without electricity and without internet, we can do this offline AI because the images are embedded, the AI is embedded in the phone, and then in 30 seconds you get an answer, referable diabetic retinopathy and not referable. So I think there are a lot of questions between doctors, optometrists, will our job go away? And I am telling them, no, it will actually enhance your work because optometrists can choose their work of doing their optometry work, and ophthalmologists can take care of their cataract and glaucoma, and the retina surgeons can treat diabetic macular edema, and so that's where I think each one's stamp can be used specifically, so that we will use the screening by an offline AI, and then anybody. So I've read a terminology called ABCD. Anybody can diagnose, or anybody can do diabetic retinopathy screening.
Thank you. I think we open it up for everybody or anybody, any comments to come in from everybody. And audience, we would request you to please put in the chat box any suggestion or comments, and we will be soon announcing our next webinar.
I have just something to add in.
Thank you.
Sure, please.
One is that yes, we do direct ophthalmoscopy for all, usually undilated. And in my clinic, at least 2 in a month, we find patients who were not aware that they were diabetic, but looking at the fundus, we ask them to get their blood sugar and all checked, and they turn out to be at least 2 in a month on that. Secondly, the non-mediatic cameras which we have, I heard Dr. David saying that they cost around $7,500 plus, but in India they cost about $4,600, and we are getting more Indian versions now, and some attachments to cell phones, as Ajit sir had also shown 2 days back. Those can be used. Those cost just about $200 and give us an indirect ophthalmoscope kind of vision. And regarding the legal implication, we should not be so much worried. It has steps. One is that there should be omission, then there should be harm. The harm should be because of omission. And all these things put together, much well before that, we do get to know that the patient is having some trouble, and we do handle those. I think it was a wonderful presentation with the whole team, all those who spoke, and Dr. David, Dr. Mahesh, Dr. Natarajan, Dr. Sumit, and of course, Professor Monica, Ajit sir, everybody. Excellent. Over to you, Monica.
Yeah, Monica,
you,
just a
Rajesh.
last comment.
Sure, sir. We love to hear that.
No, I don't want, I'm not against direct ophthalmoscopy, because I learned ophthalmology in 80s using direct ophthalmoscopy. And
Yes.
I recommend now, because of the COVID time, not to go near the patient.
Yeah,
The
you're
best
right.
is to indirect,
course.
which I think all of us have to learn. And the same is, I think we have to merge with the technology, and I'm not against the direct. And somehow I tell direct is not for ophthalmologists, but it should be for the physicians. I don't know. But I think now everybody should switch over to a non-Medriatic camera. And we are now coming out with a guideline, which we have sent it as a All India Ophthalmic Society to it will be published in IJO. It's on the review process, where we are following NHS. NHS has done more than 5 million people and found that using 1% tropicamide has no problem. Even though we know that theoretically angle closure glaucoma can happen, and which we have to keep it in mind. But I am also recommending the Government of India. I met the Health Secretary, Preeti Sudan, in Delhi. I met the Health Minister. So I am trying to print a proper document. Use a non-Medriatic camera by anybody. But in case you can't get an image, there is no use of having a non-gradable image. You need a gradable image. If not, then use a 1% tropicamide and have an access to an eye doctor nearby. For example, you're in a village. I'm sure 10 kilometers away, there will be a taluka hospital. Before you do it, you tell them that I'm going to do a dilatation. If there is a secondary glaucoma intent, I'll send you the patient by afternoon. Please take care. You cannot prescribe Diamox or IV mannitol that time, because patient may be old and have kidney problem, and then they will have more medical problem rather than eye problem. So I think we have to keep that 1 in whatever 100,000 secondary glaucoma, angle closure glaucoma. So I think in depth, I'm actually working on. I'll be happy if my email can be circulated by Oli to all. So I would like to communicate with everybody who was in the panel today, specifically with David and Bhardwaj, where I would like to make an advisory to entire optometry and ophthalmologists, where we should have a common advisory given to everybody as a preferred practice for the optometrist and non-optometrist and an ophthalmologist. Because I think we need a team, maybe the general practitioners, diabetologists, endocrinologists, and physicians to be take part in this.
Thank you so much, sir. I think you've really made our day. It's real as educationist, as an academician. I think my whole curriculum will now focus on this. We will look into it, and we will make sure that the future optometrists understand the role and what they have to serve in the society.
So I'm wearing the optometrist tie.
Oh yeah, I have the same tie, Dr. Natarajan.
I got it from the optometry only.
Thank you.
Thank you so much.
Thank you. Thank you all.
Any comments?
Thank you for patronizing us. It's wonderful.
I would,
to have you.
yeah.
Yes,
I would like to ask the final comment from Dr. David or Dr. Bhardwaj about what are their advice for our students. Like, I know the standards of education, the training in US is like if you do OD, then you are exposed to such a extensive. You have a training about the DR screening. What are your advice to the trainers, as like the teachers in optometry, the optometry institution in India, that how can they upscale the level of training, and how can they, because diabetic screening is not an end, it's a start. But DR screening has to be learned. It's an art to be learned. And as I said, that it's a start and it ends with the retina surgeon. It's a whole cycle from counseling, primary, secondary, tertiary prevention. But now we are stuck on the primary prevention, the secondary, like early diagnosis. So what you suggest to the optometry students and the optometry organization who are academics, academician, that how can they enhance the training of the future optometry in sensitizing towards these DR screening protocols and any certification courses, etc.?
I think
we made a day today itself. Today itself is a learning that today sitting here in India, we're learning from the best of experts in US. So thank you. Please give us your insights on it, sir.
So I think when we teach students, before dilation, they should definitely look at the slit lamp, but they should look at the anterior chamber angle just to make sure the angle is deep, as Dr. Natarajan mentioned that some patients have narrow angles, they can develop glaucoma if you dilate them. And so tropicamide is better because it's like it affects your sphincter muscle. Phenylephrine, sometimes in pregnant women, we generally don't use. It's a sympathomimetic agent. So I think it's important for students to look at the anterior chamber angle before they dilate in the practice. Slit lamp, they should be trained in slit lamp. And then with the direct ophthalmoscope, we generally don't use it here. I don't use it in my practice. I dilate most of my patients. Then we take photographs on the patients. And then after that, 78 or 90 or BIO, I do on everyone. So in India, it's a different situation because the practice style is different. They cannot dilate the patient's eyes. So it's very hard, like Dr. Rajesh Bhardwaj said, that he generally has non-mydriatic camera. He is taking pictures and he is doing direct ophthalmoscopy. But at this time, because of COVID, we cannot do direct ophthalmoscopy because that's very close. So I think we can enhance our profession by training them more in eye diseases, which we were not trained. When I was a student at Rajendra Prasad Eye Center, we were not trained in eye diseases. So I don't know, that was 30 years back. So it has, because of Dr. Ajit Bhardwaj and Dr. Monica Chaudhary, the profession is increasing, it's improving quite a bit. And Dr. Bhardwaj. So I'm just very happy to see our optometry in India has progressed quite a bit. And thank you to Dr. Natarajan and thank you to Dr. Grover.
Thank you so much. Thank you so much, sir.
Encourage them to please join the organization.
Right. If
Dr. Natarajan has shared his mail ID and we will share it with everybody. We'll look for it. Yes,
Yes.
Ori? Yes.
So I suggest that we have more papers between optometrists and ophthalmologists in India, which is happening. but it's not happening like the US. And I think I always say copying America for the good things is good, not to copy the fatty food or the Coke.
No. You're right, not the fatty food.
So,
Yeah.
so David is an example and me an example that we are looking trim.
Yeah.
So that's good for preventing diabetes.
Oli, you have any question or should we talk about the next program?
Next program, we have taken all the questions, sir.
Yes.
Okay, understanding that telemedicine is the future and telemedicine is the way to go. We are working extensively on this subject, and you have seen our last presentation as well as this. We talked a lot on telemedicine. And in order to improve the skills of optometrists to how to take pictures of all segments of the eye on all diseases of the eye, we will have a very specialized talk on next coming Saturday, that's 2nd of May, on how optometrists can take pictures with minimum of instruments by a very experienced ophthalmologist from Bombay. He is Dr. S.S. Bhatti. You will see how with just use of your mobile camera can help you to not diagnose, but take best of the quality pictures and send it to ophthalmologist with minimum attachments. And that's something very, very practical. He has demonstration, he has PowerPoint presentation, as well as practical ways of how we can enhance our telemedicine practice by using minimum equipments and minimum instruments. Thank you very much. With this, I'd like to thank each and every speaker, each and every person on the panel, and Dr. Natarajan for volunteering and enlightening us. And we look forward for more of these sessions in future. Thank you.
Thank you so much, everybody.
Thank you.
Thank you.
Thank you.
Thank you so much.
Thank
Stay
you.
healthy.
Bye-bye.
Stay healthy.
Thank you.